Hi everyone. I'm Dr. Rama,
Hi.
endocrinologist with Magna Centers for Diabetes, Obesity and Endocrinology, Bangalore. This will be the first in a series of chats with doctors, so that we can understand more about diabetes and endocrine disorders, etc., from the point of view of other specialists. So patients with diabetes and endocrine problems go to several doctors. They don't just go to endocrinologist. So it's important to know the perspective of both the diabetes specialist and the orthopedic doctor. So when you go to a diabetes doctor or when you go to an endocrinologist, they may ask you to meet some other doctor for a particular ailment. So what is it that is there? I mean, how we need to handle these issues is always a problem for many people. So this series of chats with doctors from various specialities will start today, and today will be the first session which we are recording. And please let us know the feedback in the comment section on this YouTube video. Today we have with us Dr. Prithviraj. So Dr. Prithviraj, can you just introduce yourself? Where are you from? Where did you do your studies? And where are you working now? What do you do? What do you like to treat? I mean, what is your specialization?
Good evening, everyone. I am myself Dr. Prithviraj. I am from Andhra Pradesh, actually basically settled in Hyderabad, presently working as consultant endocrinologist at Magna Centers, Filmnagar, Hyderabad. I pursued my MBBS from Andhra Medical College, Visakhapatnam. From there on, I moved on to North India for my post-graduation MD Internal Medicine. I did from PGI Chandigarh, and from then on, I moved on to West India, that is Mumbai. I did my DM Endocrinology from Topiwala National Medical College and Nagar Charitable Hospital, and I worked as an assistant professor there for almost a year and shifted recently to Hyderabad and started my practice.
Dr. Prithviraj, where are you originally from? You belong to Visakhapatnam only?
It's nearby Visakhapatnam, Rajahmundry, sir.
So we have a doctor from Rajahmundry, and you did your MD Internal Medicine from PGI Chandigarh. That's a great place to do MD Internal Medicine in. Okay. So, and
Yes.
after that, you've gone on to do DM endocrinology from one of the leading centers for endocrine training in India. And after that, where are you working, Dr. Prithvi?
Currently, I'm working as a consultant in Magna Clinics Film Center, Hyderabad, and again in Pace Hospitals, High Tech City, Hyderabad.
So we are proud to have Dr. Prithvi in our Magna centers in Hyderabad. And welcome to you, Dr. Prithvi. And
thank you.
And next is Dr. Kannan. So, Dr. Kannan, can you introduce yourself?
Hi, everyone. My name is Dr. Kannan. Thanks for inviting me here to have this chat with you guys. So, I am a consultant orthopedic surgeon based out of Bangalore. So, I've lived all my life in Bangalore, born and brought up in Bangalore. I did my MBBS from Rama Medical College, and I did my MS Ortho from Jubilee. And so I further, after that, specialized in hand surgery and upper limb surgery quite extensively. So I trained in all aspects of upper limb surgery, including pediatric hand, congenital anomalies, and we do a lot of brachial plexus surgeries as well. So I spent a year and a half in Japan training in brachial plexus surgeries as well. So I trained extensively for a couple of years in the US, but my first training point was CMC Vellore, which was one of the best places to learn hand surgery from. And the last fellowship I did was a pediatric congenital hand fellowship from Dallas, USA. So I've been practicing in HOSMAT Hospital, which is an exclusive orthopedics hospital in Bangalore. And I head the hand surgery department there, and we do a huge number of upper limb and hand surgery cases in that hospital. I'm glad to be a part of Magna Clinic now, and so hopefully looking forward to a fruitful partnership. So that's about me.
Welcome, Dr. Kannan. So let's dive straight into the topic today. The first question will be to Dr. Prithvi. So what are the top orthopedic problems that you see in your clinical practice? You've been practicing endocrinology for the last 5-6 years, I think. So what is the top ortho problems that you see in your patients with endocrine problem, mainly diabetes? I mean, of course, most of them have diabetes, isn't it? So,
okay, coming to diabetes, people complaining of the orthopedic and musculoskeletal problems. Besides diabetic foot, the most common problem we come across in our OPD setting or clinic is the low backache or knee pain or carpal tunnel syndromes, or frozen shoulder or diffuse musculoskeletal pain, complex regional pain syndromes. These are the most common uh, musculoskeletal problems and orthopedic problems which we can come across in a daily OP basis. Besides the most complicated part like diabetic foot and Charcot's foot.
What do you feel is the most common problem? What do you feel is the most troublesome ortho problem? And what is the most dangerous ortho problem?
In coming to clinical practice, most common is frozen shoulder seen in diabetic patients, OP clinics. And most troubles and most challenging is Charcot's neuropathy with osteomyelitis is one of the most troublesome and challenging to treat. Most dangerous one is the osteomyelitis, active osteomyelitis, infective osteomyelitis of diabetic foot, which is actually debilitating and life-changing for the patients.
Question to Dr. Kannan. So how should shoulder pain be approached in a patient with diabetes? What is a frozen shoulder? How do we recognize it?
So just to reiterate, some of the most common upper limb diabetes, musculoskeletal problems, to start from the top, is one is the frozen shoulder for sure. The second thing is you can have tendinitis around the elbow, for example, like the tennis elbow, which is aggravated. And very commonly what we see, at least I see in my practice with diabetes, is carpal tunnel syndrome, associated trigger fingers, and associated something called as recurrent stenosynovitis. So these are very common issues associated with diabetes. We may probably see at least one or two each of these cases every day. So coming to frozen shoulder is a very common problem. Unfortunately, the basic science behind frozen shoulder is very poorly understood. And the exact association between diabetes and frozen shoulder is also very poorly understood even to date. And basically, as we know, the shoulder has a covering. Every joint in our body has a covering, which is called as a capsule. And the shoulder joint, being a hypermobile joint, has a large capsule because it has to give way to quite a large distance to give us the mobility that we have in our joint. And for some reason in diabetes patients, the capsule shrinks and causes a decrease in the space available for the shoulder to move. And therefore, you have a decrease in the range of motion. See, shoulder pain can happen for two reasons in diabetes patients. One is the frozen shoulder, and the second one is inflammation in the joint. So when there is a painful decrease in the range of motion, it is frozen shoulder. When there is only pain, it's probably because of inflammation. So these are the two major groups of patients that you would see with diabetes and shoulder issues.
So you're basically saying that if there is trouble moving and if you're not able to move your shoulder and there is pain, it's most likely it's a frozen shoulder. And if it's only pain and you're able to move your shoulder, it is probably an arthritis.
Kind of inflammation or bursitis.
Some sort of inflammation. Yeah.
Yes.
That's great to know. That's great to know. I mean, talking to specialists from other specialties really opens, this thing. So, Kannan and also to Prithvi, I mean, he can also answer this as an endocrinologist, actually. So why do you think, why is it more common in diabetes? I mean, is it due to, what is the mechanism? I mean, for doctors who are listening in and even for people who are curious. So when you take 100 people without diabetes and 100 people with diabetes, what is the difference in the per year occurrence of frozen shoulder?
All the epidemiological studies till now showed that the incidence of frozen shoulder in diabetes is 3 times that of the normal population. In normal population, after 40 years, it is seen in around 2 to 4% of the population we can see this frozen shoulder. Whereas with diabetes, it can be seen in 10 to 30% of the people who are suffering with diabetes after 40 years can develop this complication, unfortunately, which is...
So it makes it a very common, isn't it? 3 to 4 times. And the prevalence will be somewhere near 15%, no?
Yes, sir. 10 to
15%. So 1 in 10 person with diabetes can have a frozen shoulder. So if you are practicing diabetes or if you're taking care of patients with diabetes, every 10th patient will have a frozen shoulder. So it's a very, very common problem. Why does this occur? I want to hear both the orthopedic surgeon and the endocrinologist talk about the mechanism. It's important for us to understand why having that, what is the blood glucose is high, how does it affect only the shoulder? Why not the elbow joint? Why not the wrist joint?
Pathophysiologically speaking, the excess glucose in the blood is converted into the advanced glycation end products, which can which can cause the collagen not to function properly and stiffen the joints, stiffen the capsule around the shoulder joint. But why only shoulder joint? It's still, the answer is not addressed, I think, still now. The answer that there is no correct answer till now for why the shoulder joint is only more affected than the other joints.
To just add in there is no conclusive evidence of what causes frozen shoulder in diabetes patients, or what is the relation between high sugars and shoulder joint. But what makes the shoulder joint stand out is that it has a large capsule and it has a large amount of, the mobility is huge. So what gives us a clue about what causes in frozen shoulder is that any kind of small injury or something else triggers a reaction which is disproportionate or is much higher than compared to the other joints, because the capsule is much tighter in the other joints and it's much closer. So because of this increased play and space in the shoulder joint probably triggers some mechanism in which diabetes patients seem to shrink the tissue very quickly. And as Dr. Prithvi said, it's a very, very common problem. And the first thing that we ask the patient when the patient presents to us with a shoulder pain is, how are their sugars? So that is the first question that we ask instead of actually examining the patient or looking for other clues.
Oh, it's so common, is it? So that means that you're actually recognizing diabetes through the presence of shoulder issues, isn't it? So
I think I might have diagnosed more diabetes patients through shoulder pain than anything else. Yeah.
Okay. That's fantastic to, I mean, it's a beautiful insight coming from you. And also another thing, what I was curious about is, for those people, those listeners, who are actually facing shoulder pain and they have diabetes, what is the prognosis of this? I mean, is this uniformly bad? I mean, will it not improve? There are people out there who may be actually having a lot of pain. So they might have, that's when you Google and then they reach this video. So can you tell us something about what is the prognosis, what happens over a period of time, and what are the treatments?
Yeah. So before we go into the prognosis, this is what I would tell the patients, all my patients. See, frozen shoulder goes through 3 typical stages. The first stage, which lasts for a couple of months, is extremely painful. It's a painful stage where your shoulder starts to stiffen with an extreme amount of, it's an unusual amount of pain that you have. So that is the first stage. That is a stage of pain. It's a painful stage. The second stage is the stiffness, where your pain starts to reduce, but your shoulder seems very, very stiff. And this lasts for about 6 months or so. And so the third stage is the stage of thawing, or when your movement starts to come back. And this is not as painful as the first 2 stages. And this also lasts for about 3 to 6 months. So once you have a frozen shoulder setting in, or you diagnose it, the course, it runs through it takes about 12 months to 16 months for the whole thing to get back to its normal self. And we go through 3 stages: stage of pain, which is very in the first few months, then stage of stiffness for 6 months, and stage of thawing, that is, you free up the shoulder after that. So what all studies have shown, and what anecdotal evidence and our patients have shown us, is that they usually get better. This is not something that is permanent. You have to put in a little bit of effort with physiotherapy and exercises, and it will eventually get better. And the whole time frame for this to happen could be anywhere from 6 months to 18 months, depending on patient to patient. And the treatment differs in the 3 different stages. To briefly go through, if you're very painful, you take care of the pain first rather than trying to mobilize your shoulder. Right? You can try various modalities to help yourself, like ice pack. You can use hot water fomentation. You can use something to keep under your right shoulder, whichever shoulder is affected, so that you don't sleep on that side when you're lying down at night. And you take care of the pain in the first couple of months. And in the next stage, you start stretching out and exercising to prevent the stiffness from happening or worsening even more. So this continues for a few months. So you will have to go through physiotherapy sessions, exercises, and you have to persist and do it on a daily basis so that you get better quickly or shorten the course of this disease. Now, there are various modalities available to shorten the course of this disease, right? One is pain relief, of course, to help you get better quickly and start thawing out your shoulder. The second thing is we can give you some injections. We can give you some corticosteroid or very low dose steroid injections right into your shoulder joint, which reduces the inflammation and kind of frees up the capsule a little bit. And that helps in shortening the course of the disease as well. The third thing is we can do is in extreme cases where things are not getting better, the patient is very stiff, not able to wear the blouse, not able to comb hair, not able to reach the head. So in these cases, you can do an arthroscopic capsular release. It works wonders as well, but you have to go and try all other modalities before you go for the surgical treatment. And 99% of patients do not require surgical release. The 1% who don't seem to be getting better at all can have this arthroscopic release of the shoulder.
So to be clear for the listeners out there, like basically if your orthopedic surgeon is recommending a release, so typically they should have enough disability that they're not able to reach their head or, even basic things, basic mobility of the shoulder is taken care of. So, and apart from this, is there any role for manipulation under anesthesia? Because I've seen some doctors do that also. So they will give anesthesia and move the shoulder just to break it blindly. Does that work? Or, arthroscopy is a better procedure than that.
So I am not advocating for arthroscopy, but it definitely works. Manipulation under anesthesia works. But what I'm trying to tell is that when the patient is going under anesthesia for manipulation, you might as well release the capsule and get a better deal out of the whole thing. So manipulation under anesthesia was the commonly done procedure about 10-15 years ago, for sure.
Does it occur after manipulation under anesthesia? So
the patient has to persevere and exercise and go through the rehabilitation process immediately after the procedure. And if you do not exercise after the procedure, you are going to go back to the stiffness that was existing before the manipulation or release. So it all boils down to exercising, putting in the effort. So whenever a patient comes with stiffness, this is what I tell them. See, my job is just telling you that this is the problem. But it is your job to exercise and get your range of motion back. And that cannot be done by any medication, cannot be done by the doctor. It has to be a wholehearted effort by the patient to shorten the course of the disease. Yeah. So it doesn't matter what you do. Eventually, most patients get back their range of motion. So to reduce the pain and stiffness is what we are trying to do, and shorten the course of the disease is what we are probably trying to do. Yeah.
So basically, it impacts the quality of life badly, and then by your intervention, you hope to improve the quality of life by a decent amount. Basically,
yeah.
Got the idea, Dr. Kannan. So one question, Dr. Prithvi. Will improving because Dr. Kannan was speaking about physiotherapy, stretching, in the acute phase, mild painkillers, not prolonged painkillers, because patients with diabetes and NSAIDs don't mix well. Actually, so if you are having frozen shoulder, physical therapy and being guided by a experienced orthopedic surgeon is way better than actually taking painkillers on your own, because it can damage your kidneys. That is something that I would recommend you not to do if you have a pain in the shoulder. But another thing that I want to ask Dr. Prithvi is, is there any evidence from the literature or from your experience where improving the control or giving particular type of diabetes drugs, does that improve frozen shoulder?
Yeah, coming to treatment perspective, better glycemic control, they can definitely shorten the duration of the pain or whatever the inflammatory process going on in the shoulder, and improve the quality of life. And it is also shown that better glycemic control can prevent happening the frozen shoulder in the other shoulder joint also. So diminishing the other risk factors like dyslipidemia, controlling the hypertension, and glycemic control, overall glycemic control may not correct the frozen shoulder pain immediately, but it definitely helps in the improves the quality of the life and preventing the other complications they can develop in the future. But that whatever the data and the studies have shown that glycemic control per se has no effect in a frozen shoulder process in the treat pain part or treatment part, but it can definitely reduce the length of the pain, duration of the frozen shoulder, the process part, and improving healing. Improving healing can be seen with the better glycemic control.
So you're saying that there's evidence that if you control the glucose well, then the frozen shoulder may not recur on the opposite shoulder. So, and how often does the recurrence occur, Dr. Kannan? I mean, how commonly, if you have frozen shoulder on one side, how often does it occur on the other side?
If I'm correct, there is about 60 to 80% chance that you will get it on the other shoulder as well.
That's a very high percentage. So
very
I think, if you have diabetes and if you're not gone to your diabetes doctor for several months or years, so it's time for you to meet your diabetes doctor and get your diabetes under control, because there seems to be some sort of relationship between diabetes and this thing. I would not say that, like Dr. Prudvi put it very nicely. So it's not that, when you have severe pain in the shoulder, controlling the glucose is not going to reduce the pain immediately, but it can improve the overall course of the illness, since it's an illness it's a chronic illness which spans 2 years. So it is something that can take care of the whole thing and also prevent occurrence in the opposite shoulder. It's a very painful and, troublesome condition. So because we are doing a Zoom interaction with laptops, we can't demonstrate to you some exercises for patients' benefit, for the sake of for releasing the frozen shoulder. I think I'll have Dr. Kannan, share those videos very, very soon. So thanks all three of all of you. All thanks to me also. Thanks to both of you rather. So I'm thanking both of you. So we'll wind up here, and then we will discuss some more ortho problems in diabetes very soon.